talk about today are breakpoint changes that happened at CLSI. We'll talk about the cephalosporin breakpoint changes as well as the carbapenem breakpoint changes. These are changes that you will have seen in the January 2010 version of the CLSI M100 document. That's where the cephalosporin changes were published. And then most recently in a supplement that came out from CLSI, and that's where the carbapenem breakpoint changes happen. What I want to talk about today are the kind of the data that were used to make those decisions, and then some of the implications of those decisions. So let's dive in. And as I mentioned, we're going to talk about these two breakpoint changes. And you can see this is kind of an older talk because at the time the carbapenem breakpoints hadn't come out. The cephalosporin breakpoint changes occurred for more than just the cephalosporins. It was for cefazolin, acetreonam, ceftriaxone, and ceftazidime. Those are drugs where breakpoint changes occurred. I also listed cefepime on here, and that's because the cefepime breakpoints were reanalyzed, but it was decided to keep the breakpoints where they currently are. So, and in fact, the breakpoints for several of the beta-lactams for Enterobacteriaceae were reevaluated. And let me just make that clear. We're talking about breakpoints for Enterobacteriaceae. So here I've listed the old CLSI breakpoints, susceptible, intermediate, resistant, and the new breakpoints. In addition, the last column are the screening criteria for identifying an ESBL producer. And so what you should notice is that for some of the drugs, for example, let's look at ceftriaxone and cefataxine. So there, the susceptible breakpoint used to be 8. The screening criteria for an ESBL would be an MIC of 2 or greater. Now with the new breakpoints, you can see that the new breakpoints are consistent with those screening criteria. And that means ESBL producers would probably test non-susceptible to those drugs. But if you look at ceftazidime, the susceptible breakpoint now is at 4, and that's just above that ESBL screening criteria. So we're going to talk about how these breakpoints are really meant to indicate treatment, but not necessarily identify all potential resistance mechanisms. That's something that's very different than what we've been taught to do. And so it's a difficult concept to get used to. It actually took a while for, I think, CLSI to get used to that new paradigm, but and now it's going to be a process for the implementation. The carbapenem breakpoint changes are here as well. So here the breakpoints were lowered. We have the old CLSI breakpoints and now the new CLSI breakpoints. And also the screening criteria for identifying carbapenemase producing isolate. So the carbapenemases, the most common one seen in the United States is KPCs, but now we're starting to see some new carbapenemases, and those are the metallo-beta-lactamases. I'll talk about those a little bit more at the end of this talk. But we want to make sure that laboratories can identify isolates producing these resistive mechanisms, because one, it's a concern about treatment, but also it's a very big concern for infection control. And here, in this case, all of the carbapenem breakpoints line up with the screening criteria. So isolates that are producing a carbapenemase will test non-susceptible. So this is that old paradigm that I was talking about. This is what we were doing. So the practice that was occurring in CLSI, and we were telling laboratories to implement this, is to, when there was a new resistance mechanism, and the best examples are when ESBL producers emerged or carbapenemase producers emerged. The solution was not to change the breakpoints for those drugs, but instead to identify a screening test so you could identify that mechanism of resistance. And then to have a special phenotypic test to be able to detect the mechanism of resistance, and that's why we had the ESBL test. And then that's why we had the Hodge test for the carbapenemase producers. And then if that special test were positive, you would either change the susceptibility results for the drugs, or you would send add a comment to the report saying this isolate has a resistance mechanism. Now this was really meant to be a stopgap measure. This was meant to be a short-term solution to susceptibility testing with these new resistance mechanisms. And the long-term solution was to modify the breakpoints in response to these new resistance mechanisms. Now for cephalosporins, that took a long time. For carbapenems, it took much shorter time. So now we have this new paradigm, and the new paradigm goes like this. If you isolate Enterobacteriaceae, you perform susceptibility testing and apply the new breakpoints. You report the susceptibility results without doing any additional specific tests, and these susceptibility results are meant for guiding treatment. Then there is an option for performing the special test to detect the mechanism of resistance, but the purpose here would be either for an infection control decision or for an epidemiological study. So for example, if you wanted to know what resistant mechanisms are occurring in your population, then you would do these special tests. So this is very different. Now we're telling laboratories that you don't have to detect every potential mechanism of resistance that bacterial isolate has before the physician makes a treatment decision. And it's a difficult thing to get used to. So let me tell you a little bit about how these decisions were made. So when CLSI is considering breakpoint changes, there are three types of data that are looked at. And one is the MIC distribution of a wild type or a normal population of bugs. The other one is pharmacokinetic and pharmacodynamic data. And that's an analysis where you're actually modeling what would be the level of drug, what would be the level of drug in the patient, and would that be high enough to treat an infection? And then we also look at clinical outcome data. So clinical outcome data is whether or not the drug was effective in treating an infection at different MICs. For the cephalosporin breakpoint changes, you can imagine that, and even for the carbapenem breakpoint changes, there was very little clinical outcome data. And these were for different reasons. For the cephalosporins, laboratories were trained to report cephalosporins as resistant whenever an ESBL was present. So it was difficult to find data on whether a cephalosporin would be an effective treatment. And now we're all taught that they weren't an effective treatment, but really what we know about ESBLs are that there are many different enzymes that are called ESBLs, and they have different levels of activity. For example, a 10 ESBL would have more activity probably for ceftazidime and very little for ceftriaxone. Whereas a CTXM ESBL would have a lot of activity against ceftriaxone, but very little against ceftazidime. And would ceftazidime be a good drug in that case? So there was little outcome data, and most of the decisions that went into setting the breakpoints were based upon this BAPD analysis, this modeling analysis. And I'm going to talk a little bit about that.